at ELCC, we also had an update from CheckMate 9LA. Now, this is a trial of a 4-drug combination, really looking at 2 chemotherapy drugs, platinum doublet given only for 2 cycles, so sort of chemo-light, in combination with Nivo-Ipi, and Nivo-Ipi is doing the hard work given long-term. And this was compared against 4 cycles of histology-specific chemotherapy. Now, we know that the trial was a positive trial compared to chemotherapy alone, and at the ELCC meeting, Dr. Pazarez gave us additional data about biomarker predictivity, specifically around TMB, tumor mutation burden. Now, the key issue is, does TMB predict benefit from Nivo-Ipi? And this has been a debate which has been grumbling along in the world of lung cancer for some time now. And the signals that we have were initially very promising, showing that it might predict benefit with positive PFS. But actually, OS, we've never really hit the OS endpoint in prospective trials. CheckMate 227 was unfortunately negative for the predictive utility of tissue TMB. So what did CheckMate 9LA show? So in CheckMate 9LA, we had very nice data using tissue TMB at a variety of cut points, typically the 10 mutation per megabase cut point using the Foundation 1 assay, and also blood TMB using the Guardant Omni assay at a variety of different cut points using the 16 or 20 threshold. The bottom line is that neither blood nor tissue were predictive of overall survival in CheckMate 9LA, although they were predictive of progression-free survival. So I think we've got a lot more to better understand about the role of tumor mutation burden. Actually, maybe we're just focusing on the wrong endpoint, overall survival, and maybe actually it is quite a good biomarker for progression-free survival. But if it's not useful for overall survival, then actually is it really useful at all? And do we really need it? And what is it really bringing in addition to what we're already using, which is PD-L1 status? Now, if we are using CheckMate 9LA, perhaps the strongest indication is in the PD-L1 negative patients. And you could make an argument which says, well, in this group of PD-L1 negative patients, those with the greatest TMB might have the best progression-free survival, and they might be the ones I might want to pre-select for this option. But of course, we also know that TMB tends to predict benefit from monotherapy, and potentially has a role with triplet with chemotherapy as well. So I think there's a lot of uncertainty still around TMB. Is it best measured by tissue or blood? What's the optimal cutoff? Where do we use it? We still haven't really found a definite home for this biomarker, and a lot of work still needs to be done in that space.